USMLE-style question on cerebral edema. A 58-year-old man presents to the emergency department with sudden onset right-sided weakness and difficulty speaking. His symptoms began 3 hours ago. He has a history of hypertension and diabetes mellitus. On examination, he has right-sided hemiparesis, facial droop, and expressive aphasia. Non-contrast CT scan of the head shows no hemorrhage. He is started on intravenous thrombolytic therapy. Over the next 48 hours, the patient develops worsening lethargy and confusion. Repeat CT scan shows hypodensity in the left MCA territory with midline shift and effacement of ventricles. Which of the following mechanisms is most responsible for his clinical deterioration? A. Increased intracellular fluid due to loss of ATP-dependent ion transport. B. Increased extracellular fluid due to blood-brain barrier disruption. C. Increased cerebrospinal fluid production. D. Increased systemic blood pressure leading to hypertensive encephalopathy. E. Increased osmotic gradient from excessive IV fluids. Answer B. Increased extracellular fluid due to blood-brain barrier disruption, vasogenic edema. Explanation: this patient initially had an ischemic stroke but worsened over 48 hours due to vasogenic cerebral edema. The two main types of cerebral edema are 1. Cytotoxic edema, early phase, within hours of stroke, due to loss of ATP-dependent ion transport, intracellular fluid accumulation, common in early ischemia, hyperammonemia, hepatic encephalopathy, SIA. 2. Vasogenic edema, late phase, 24 to 48 hours after stroke, due to blood-brain barrier breakdown, extracellular fluid accumulation, common in late ischemia, trauma, tumors, hemorrhage, inflammation. In this patient, the initial stroke, ischemia, caused cytotoxic edema, but by 48 hours, the BBB became permeable, leading to vasogenic edema, which increased intracranial pressure, ICP, causing midline shift and neurological decline. Incorrect options. A. Increased intracellular fluid due to loss of ATP-dependent ion transport, cytotoxic edema, occurs early within hours in stroke, but this patient's deterioration occurred later, 48 hours, indicating vasogenic edema. C. Increased cerebrospinal fluid production would cause hydrocephalus, but this patient has midline shift and cerebral swelling, not ventricular dilation. D. Increased systemic blood pressure leading to hypertensive encephalopathy would cause global cerebral dysfunction, not stroke-related localized edema. E. Increased osmotic gradient from excessive IV fluids could cause osmotic demyelination syndrome, ODS, but this patient has vasogenic edema due to stroke. This question tests knowledge of cerebral edema mechanisms, its timeline in stroke, and the difference between cytotoxic and vasogenic edema.